Peter Lai was just 7 years old when he said everything began to change. He started falling and had difficulty getting up again. He also struggled to get out of bed. In elementary school, he sat on the swings as his schoolmates played kickball during PE. Strong winds would either blow him down or make him walk slowly, as if in slow motion. He subsequently required braces to support his legs when he walked, and he tended to walk on his toes to keep his balance. By 8th grade, he was falling so frequently that he required a wheelchair. He also developed scoliosis, a curvature of the spine, which progressively got worse such that he needed spinal fusion to fix it when he was 15. This procedure further limited what he could do. Over time, his breathing function declined and he required a BiPAP machine and then a ventilator to keep him breathing. Peter Lai was diagnosed at the age of 9 years with Becker muscular dystrophy, and he narrated his story in the memoir titled Fueled by Misery. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. In this episode, we will delve into the world of muscular dystrophy. The history of muscular dystrophy goes way back before Peter Lai experienced his illness. In his book titled The Nervous System of the Human Body, published in 1830, the Scottish surgeon Sir Charles Bell documented the case of an 18-year-old man who had presented with progressive muscle wasting from about the age of 10 years old. Bell wrote that the problem began with a weakness in the thighs which disabled him from rising. He also added that he will twist and jerk his body to throw himself upright from his seat. Bell found that all the muscles of the lower extremities, the hips and the abdomen were debilitated and wasted, and he pointed out that the quadriceps femoris was more wasted than the vasti. Beyond the muscles, Bell also noticed that the man had a slight curvature or projection of the lumbar part of the spine. I got the above account of Sir Charles Bell from a book by Alan and Marcia Emery titled The History of a Genetic Disease. The Emerys had carefully traced the evolution of our understanding of Duchenne and other muscular dystrophies, and they pointed out that Bell's patient is considered to be the first reported case either of Duchenne or its milder cousin Becker muscular dystrophy. As Duchenne muscular dystrophy became recognized as a disorder, clearer descriptions of its clinical features started to emerge. For example, the Emerys referred to the 1833 case of two brothers in Naples who became the first familial cases to be reported. This report identified such characteristic features of Duchenne muscular dystrophy as enlargement or hypertrophy of the tongue, the calf, and the deltoid muscles. The selective involvement of muscles, so typical of the clinical manifestation of muscular dystrophies, also seems to correspond to the pathological changes found either at postmortem or later on after muscle biopsies. And the first such study in Duchenne muscular dystrophy was carried out by Richard Partridge in 1947. According to Emery and Emery, Partridge reported the case of a 14-year-old boy who had an autopsy. The report showed fatty degeneration most marked in the deltoids, sternomastoids, soleus and gastrocnemius muscles with relatively little or no involvement of other muscles. This is just for the experts, but also to emphasize the selective involvement of muscles in muscular dystrophy. Emery and Emery also noted the contributions of the physicians who subsequently helped to enhance our understanding of Duchenne muscular dystrophy, and two of these stood out. This is because of their systematic rather than anecdotal approaches to the disease. The first and eponymous personality was Duchenne de Boulogne, the French neurologist who, from 1861, reported on the clinical and pathological findings of 12 cases. The first was a 9-year-old boy who presented with delayed walking and difficulty ambulating. The Emerys noted that it was perhaps Duchenne's contribution to muscle pathology that established his association with the disease, so much so that it has come to bear his name. Rather than wait for death before examining the nervous system, Duchenne carried out muscle biopsies of living subjects, a procedure for which he designed a dedicated punch biopsy needle. In this way, Emery and Emery said Duchenne recognized another pathological feature of muscular dystrophy, hyperplasia or excess of the connective tissue. Furthermore, Duchenne also recognized the disease's predilection for boys, and he distinguished it from progressive muscular atrophy and acute poliomyelitis, close mimics. The second person the Emerys credited for the early delineation of Duchenne muscular dystrophy was Edward Meryon. In 1851, the polymath presented the cases of 9 boys across 3 families who had difficulty running and jumping, a tendency to trip, and later difficulty in climbing stairs. In 2 of the families, chair dependency set in between 10 to 11 years and death between 14 and 16. The disease was milder in the 3rd family, a feature that made Emery and Emery suggest that this was perhaps Becker rather than Duchenne muscular dystrophy. To his credit, Meryon went on to report a 4th family. From the foregoing, quite a lot was recognized about Duchenne muscular dystrophy very early on. Apart from the features already highlighted, there are other distinct neurological clinical features of Duchenne muscular dystrophy. These include an onset age between the ages of 2 and 5 years, a delayed onset of walking beyond 18 months, a waddling gait, and a tendency to toe walking. It is also characterized by difficulty rising from the floor, acute illness-associated weakness, and wheelchair dependence by about the age of 10 years. On examination, characteristic findings include calf hypertrophy or enlarged calves, absent reflexes, except perhaps at the ankles, and strong plantar flexors and everters. Those are the muscles that bend the ankles. Children with the disease also demonstrate a positive Gowers sign. This is a feature that was first described in 21 boys with the disease by the famous neurologist William Gower in 1879. On attempting to get up from the floor, the children would adopt a prone position on all fours before attempting to stand. They would then walk up their legs with their hands. This sign has since been described in other disorders in which there is weakness of the proximal or upper leg muscles, but it is still quite suggestive of Duchenne muscular dystrophy. A more recent illustration of Gower's sign and the associated mobility problems that are associated with Duchenne muscular dystrophy was provided by Heather Vincent in her memoir titled It's All Right, Mum. Vincent wrote that life for our family cruised along happily until David was 4 years old and he began attending the public kindergarten. On his second day, the supervisor raised concerns about the unusual way he climbs up the steps of the slide and how he runs awkwardly. When he was examined by an orthopedic specialist, she said he used his hands to lever himself up to a certain point and then pushed them against his legs to inch himself laboriously up to a standing position. David also walked on his toes, and Vincent explained that this was because his Achilles tendon was very tight. His other mobility difficulties were poor balance, difficulty climbing up and down stairs, and recurrent falls for which he required a manual and then an electrical wheelchair when he was 8 years old. The other neurological manifestations of Duchenne muscular dystrophy include global developmental delay, learning difficulties, anxiety, obsessive compulsive disorder, attention deficit hyperactivity disorder, autism spectrum disorder, and a heightened risk of epilepsy. And beyond the neurological features of Duchenne muscular dystrophy are a wide range of systemic features. And these include cardiomyopathy, cardiac rhythm disorders, respiratory insufficiency, kidney stones, constipation, and reflux. And there is also what is called Chilaiditi syndrome, and this is the interposition of the colon between the diaphragm and the liver. Becker muscular dystrophy, which Lai suffered from, has a milder phenotype or appearance than Duchenne. It has an older onset age of about 8 years, although severe forms may present earlier than this. Loss of ambulation also occurs much later, between the ages of 26 and 56 years, and it has a longer survival than Duchenne muscular dystrophy. Other distinguishing features of Becker from Duchenne muscular dystrophy includes less frequency of the Gowers sign. There's also less calf hypertrophy and contractures, and the respiratory function is typically preserved. Duchenne and Becker muscular dystrophy arise from mutations in the gene that codes for the protein called dystrophin. When the genetic mutation is complete and the deficiency of dystrophin total, the severe clinical picture that emerges is Duchenne muscular dystrophy. But when the mutation is incomplete and the deficiency of dystrophin only partial, the disease that emerges is Becker muscular dystrophy. It's really quite simple. The dystrophin gene is the largest human gene, and it lies on the X chromosome. The X-linked transmission explains why only males develop the full-blown picture of Duchenne and Becker muscular dystrophy. This is because, unlike females, males have only one X chromosome, and therefore they do not have a second X chromosome to counter the effect of their single faulty. Females who inherit the defective X chromosome, however, carry it silently, usually, and then transmit it to their male children in whom it manifests fully. Occasionally, however, females can become manifesting carriers and present with mild to moderate muscle weakness, muscle pain, cramps, and a heart muscle disease called X-linked dilated cardiomyopathy, XLDCM. David's family is a good example of how the disease is passed on. His mother carried the mutated dystrophin gene silently, never manifesting the disease. Her brother Peter, however, had the full-blown picture of Duchenne muscular dystrophy. He had poor sucking when he was born, didn't walk until he was 2, and couldn't keep up with the other children, either physically or intellectually. He started falling, grew weaker and weaker, and finally needed to go into a wheelchair. He also developed breathing difficulty, especially at night, and died of this at the age of 16 years. David's 2 sisters each had a 50% chance of being carriers, and none of them manifested the disease. We now come to the main investigations for Duchenne muscular dystrophy, and this includes checking the muscle enzyme creatinine kinase, genetic testing, MRI scans of the muscles, and occasionally now a muscle biopsy. The management of people with Duchenne muscular dystrophy is multifaceted, and it revolves around bone health management, breathing management, and the assessment and care of heart function. For a very long time, the only specific treatment was steroids. But there has been an exciting development in the treatment of Duchenne muscular dystrophy in recent years. And this is the emergence of genetic treatments, and they include such names as eteplirsen, ataluren, drisapersen, golodirsen, vitolersen, and dilantrosogene moxaparovec. I tried. Duchenne and Becker are just two of almost countless numbers of inherited muscular dystrophies that have now been described. And they are all united by deficiency or dysfunction of the proteins that form the structure of muscles. And the second most common muscular dystrophy after Duchenne is myotonic dystrophy type 1. A most illustrative portrayal of this disorder was narrated by Anne Woodbury in her memoir titled Surviving Myotonic Dystrophy. Woodbury described how she spent 40 years experiencing the dynamics of caring for her husband and all their 4 children who were diagnosed with the disorder. She had no idea that her children's struggles were due to a neuromuscular disease until one of their cousins was diagnosed. Michael, the worst affected of her children, was the first to be diagnosed within the family. Woodbury said she had excessive amniotic fluid during his pregnancy, and like all her pregnancies, she needed a cesarean section. Michael struggled to breathe after birth, and he required care in the intensive therapy unit, requiring supplemental oxygen for 2 months. Because his soft palate was weak, Michael also regurgitated his meals and couldn't pronounce consonants, what Anne said was often a major marker of the muscular dystrophy. When a neurologist examined him, he showed classical signs of myotonic dystrophy. Significantly, he had difficulty releasing his grip after 10 seconds of a firm handshake. His tongue also tensed up after it was tapped, and his thumb jerked forward and slowly relaxed when the outer palm was tapped. These are respectively called grip, tongue, and percussion myotonia. With the establishment of her family's diagnosis, Woodbury remarks that over many years I have slowly come to realize that some of the traits I had thought were natural in my children were in fact caused by the sinister little genetic anomaly that had been working in them for all these years. Amongst the features of myotonic dystrophy all or most of her children showed were extreme apathy, hollowing of the sides of the face, also called temporal wasting, and very early male pattern baldness, classical features of myotonic dystrophy type 1. They also had sloping shoulders, inability to whisper, and tent mouths, what she described as an upper lip that sits higher than the rest of their mouth, making their teeth visible. Furthermore, they had central and obstructive sleep apnea, excessive daytime sleepiness, cognitive difficulties, including lack of self-awareness, motivation, and initiative. Other documented neurological features of myotonic dystrophy type 1 are droopy eyelids called ptosis, a swan neck appearance, and foot drop. And there are also systemic features which include heart arrhythmias, ischemic heart disease, mitral valve prolapse, hypertrophic cardiomyopathy, constipation, gallstones, reflux, diabetes, testicular atrophy, gynecomastia, impotence, reduced libido, deafness, joint contractures, cataracts, myopia, retinopathy, and a corneal anomaly called Fuchs endothelial corneal dystrophy, FECD. And that is not all. There are also obstetric and gynecological complications which include spontaneous abortion, prolonged labor, retained placenta, postpartum hemorrhage, preterm birth, painful or irregular menstruation, ovarian cyst, and endometriosis. You get the picture of how systemic myotonic dystrophy is. Myotonic dystrophy is caused by mutations in the DMPK gene on chromosome 19. This is an expansion of a portion of the gene whereby a segment with the letters CTG is repeated and unusually expanded. In this segment, the letters CTG are usually repeated 5 to 37 times. The number in people with myotonic dystrophy is, however, much higher. Mild disease is seen with those in the range 5 to 100, and the classical disease is seen with those who have a repeat range of 200 to 500. And those with 1,000 or more repeats tend to present with congenital myotonic dystrophy. Woodbury's memoir demonstrated the unusual genetics of myotonic dystrophy. All the affected family members had the CTG trinucleotide repeat disorder, as it is called. Her husband Kent had 75 to 100 repeats and was only mildly affected. The children had between 350 and 550 repeats, with the older two more mildly affected than the younger two. Woodbury also observed that because this disease worsens with each generation that inherits it, the older members of the family are only just beginning to suffer from issues when they have grandchildren who immediately show the symptoms. This phenomenon is called genetic anticipation. We now come to the management of myotonic dystrophy, and a core feature of this is the surveillance for its complications, some of which, as we have seen, are potentially lethal. These include regular assessments of swallowing, mobility and breathing, echocardiograms and cardiac imaging, fasting glucose, cataract assessments, and blood tests for lipids, as well as liver and thyroid function. Woodbury's family also illustrated the different treatments of myotonic dystrophy. These included feeding tubes to maintain nutrition and prevent aspiration pneumonia, breathing support with CPAP or BiPAP, and medical treatments which include modafinil for fatigue and mexiletine for myotonia or the muscle stiffness. Other treatments as appropriate are pacemakers, regular influenza and pneumococcal vaccinations, and anesthetic monitoring. Another important group of muscular dystrophies are the limb girdle muscular dystrophies. These are classified into type 1, those inherited dominantly, and type 2, those inherited in a recessive manner. There are more than 35 distinct genetic disorders under the umbrella of limb girdle muscular dystrophies, making it extremely difficult to cover satisfactorily in a podcast like this. But we can have an idea of the disease from the memoir of Heather Markham, and she titled this Rough Waters. Markham was 12 years old when she developed difficulty walking, and she manifested an abnormal gait which she said was very slow and awkward, like a broken doll. She also struggled to get up from the floor and from chairs. Over the course of her illness, she experienced several trips and falls and sustained injuries, including to her head. She also said she endured systematic shaming and ridicule by doctors who consistently dismissed her symptoms. A neurologist, however, found weakness, especially of her right calf, ankle, and foot. He did blood tests, and this picked up an anomaly of the creatinine kinase enzyme, which was raised. On the suspicion that she had an inflammatory muscle problem, she was treated with steroids and methotrexate and later azathioprine, but her creatinine kinase levels kept rising. Apart from not deriving any benefit from the treatment, she thought the treatments were making her worse. Yes, steroids can weaken muscles. But even when her CK rose to 12,000 on treatment, her neurologist did not reconsider the diagnosis of an inflammatory muscle disease. Rather, he referred her to a rheumatologist who arranged a neurological test, the muscle biopsy. Based on the result of the biopsy, the rheumatologist then referred her to another neurologist who then diagnosed her with limb girdle muscular dystrophy. As her mobility deteriorated, she eventually required a wheelchair, something she said ripped away at her cloak of invincibility. And as her condition inevitably worsened, she started experiencing difficulties with upper limb function. Beyond the scope of deep exploration in this podcast, are other muscular dystrophies, which include myotonic dystrophy type 2, facioscapulohumeral muscular dystrophy or FSHD, Emery-Dreifuss muscular dystrophy, and oculopharyngeal muscular dystrophy. To explore the patient perspective of muscular dystrophy further, I will be speaking to Antoinette Stubbs, who wrote of caring for her son with muscular dystrophy in the memoir titled Brave Heart. Thank you very much for listening or watching this podcast in which we started an exploration of muscular dystrophy. Apart from the books I've already cited, I've also referred to the following source for this podcast, and this was by Wallace and Newton, titled Gowers' Sign Revisited, published in 1989. If you found this podcast enlightening and you want to explore the topic further, why not consider my online neurology database called NeuroChecklist? And if you want to explore neurology in simple terms, you might consider looking up my book called Surfing the Brain. And to make sure you do not miss the next episode of this podcast, why not subscribe to the iTunes, YouTube, or Spotify channels when I will be speaking to Antoinette Stubbs. Thank you very much and join me then.